I am going to use a patient scenario to demonstrate some IV infusion skills, Alaris pump skills. I don't have a script for this, so it's just going to be kind of what I think I should show you as we go along. I think the bases will be covered when it's all said and done. So this is your scenario. You have a patient who is coming up to you from the emergency room. He's got pneumonia and dehydration. So you have orders to start IV fluids at 125 an hour, and you need to get the first antibiotic going, and then he has another IV push medication. It doesn't matter what the IV push medication is for this scenario. The emergency room did put an IV in, and so that's where we'll go. So I'm going to gather my supplies. First I'm going to check my orders, make sure that I've got the right IV fluids. The IV fluids aren't expired, they look good. The antibiotic has been checked 3 times, it matches up with the order. It's for the right patient. I'm going to take the med sheet with me because I have to have something to compare my medication to. Now, having said that, this medication has a label on it that has the patient's name and date of birth. So I could get by in this situation with leaving the med sheet behind because I have a way of identifying my patient. Never do you walk in the room with medications knowing that you're going to remember. That's not right. So I'm going to get my IV tubing for the primary line. This is in a sterile package. Just imagine that, please. I didn't have any in sterile packaging. I have my secondary tubing, and I have my medication, and I have a flush to make sure that the IV is patent. And let's see, I've got labels, and I think I'm good to go. Maybe I'll take some tape so things aren't hanging. All right, let's go meet our patient. Hello, Mr. Washington, how are you?
I'm good. How are you?
I'm doing all right. I'm sorry you're not feeling well. I'm sorry you're here. We'll take really good care of you while you're here, but I know that there's things you'd rather be doing than being sick in the hospital. I've got orders to hang IV fluids, and I've got your first dose of antibiotic and an IV push medication. Can you tell me your name and your birth date?
George Washington.
Okay, and what's your birth date?
It is 12/11 of 95.
All right. Thank you, sir. Everything matches up. I'll set my stuff down. And now I know he just came up from the emergency room. His IV certainly should be patent. So I'm going to take a look at it, and it looks good. It doesn't look like it's blown up or anything. And so I'm going to go ahead and set things up here. If I really questioned whether it was patent, maybe I would flush it first to make sure, because if I have to start a new IV, maybe I want to do that before I get this all set up, but that probably doesn't matter one way or the other. All right, get my IV tubing and my IV fluids. Open up my IV fluids, checking that it looks clear. It's not expired. Yeah, it's got February of 17 for the date, for the expiration date. Take the tubing out of the packaging. One thing you can know about the tubing in packaging is that all of the clamps will be open. And you know what? I need to step away and get a trash can because this really isn't going to infuse into a patient. So I should have thought about this earlier already. So in the real world, we don't need to have this trash can here because, you're going to hook it up to the patient and it's going to work. So this is in the packaging. So I'm going to open it up. And in the packaging, when you take it out, the ends will both have sterile caps on it. That has a sterile cap on it. The sterile cap is missing, but we got to pretend, okay? And again, all the clamps are open. So we call that a full prime mode. So find a clamp and close it, okay? So the big end of this clamp is open, and as you scroll it down, you're clamping it off. That just puts you in control. What do you do first? Well, experience will dictate that. Whatever it is that you imagine might be more difficult is what you do first, because you might need two hands for it. And if you've got caps on both, then you need two hands for something, you can set the other thing down. So in this scenario, they're probably equally difficult or easy. So I'm going to take the sterile cap off that, throw that away, pull the sterile cap off of this, sterile to sterile. When you're spiking the bag, do take a little care that you don't take the bag and puncture it through, because then it's going to leak and you'll have to start over. So don't poke it through there. Give yourself some support. Okay? Hang your IV. Squeeze the drip chamber. Okay. And then I do find it interesting that this tubing leaked so much even though I had the clamp on. I don't know how to explain that. Then you're going to prime your tubing. Okay, and then close it off. Now, you have to squeeze the drip chamber before you prime the tubing. If you don't put fluid in this chamber, when the drops fall into the chamber, you're going to have drops, air, drops, air, drops, air, drops, air, and you're going to get a bunch of air in your tubing. The whole point of a drip chamber is to create this full channel of water that allows only fluid, I say water, I mean fluid, but only allows fluid to go into here. That's why it's important to squeeze your drip chamber, get some fluid in. That's a little overfilled. Now, if you really didn't like that that's overfilled, it will work, but you can always turn it upside down and squeeze some back in. Okay. All right, now I'm going to put it through the pump. Open the pump door. You have to get used to this. When you're opening and closing the pump door, you have to kind of go like push the top and then latch it like that. Okay, so open the pump door, and then when the tubing is in the packaging, it'll have this guard, and this guard is there on purpose. This piece between here and here is what the pump reads, so you really don't want to have your fingers all over it. It may change the way the reader works. So this goes in like this, and then this just pulls and sets in like that, and then you close the door on it. Check to make sure that that's going square down the middle, which it is. Okay. Now, I might have suggested that you turn the pump on first while you're doing this other stuff, because you'll notice there's a little sequence of stuff that the pump has to go through. It asks you, is this a new patient? Well, this is a new patient. He just came up from the emergency room. So I'm going to say yes. When I say yes, it clears the memory of anything that may have already been in there. So I'm going to say yes. It wants to know what area is this. This says adult ICU. You might have med-surg, you might have tele, you might have OB. And those just reference various libraries that this computer can then access. If you say adult ICU, that's fine, because it'll work in your med-surg setting. What you don't want to have is med-surg setting in a tele or an ICU area, because you might need some medicine that you then can't access. So I'm just going to say yes. And now it wants to know if I want to put some patient information in there, and we generally don't. There are ways you can adjust the volume, but you want to make sure that it's loud enough that you can hear it, but not so loud that it annoys the patient. All right, now you have on the screen A and B. If you push those, nothing is going to happen. You have to tell it by virtue of which arm you're using. By the way, we call this the brain. We call these arms. These arms come on and off. This is how you take the arm off. And then it latches here and snaps into place. Well, I think it snaps into place. I can assure you that in the hospital setting it does. Well, unless it's broken. Snaps into place. You can have up to 4 arms on one brain. Okay? So that's, you can have 4 infusions that are being managed by this one control set. So I need to tell it which one I'm using. I'm going to use this one over here because that's where the tubing is. Channel select. And this is a basic infusion. And I have to put in, it says primary infusion, the rate. Well, the ordered rate was 1.5, and that's 125 milliliters per hour. And then the volume to be infused. How much volume do you want to infuse at that rate before the pump gets to 0 and calls you into the room? Well, since this bag only has 500 milliliters in it, then I need to put 500 in there. Typically, at this rate, I would be hanging a liter bag, okay? But we work with what we have. All right, when I hit start, then it's going to infuse. So I need to connect it to my patient first. Find my alcohol. Okay, so you hear that beeping? If I had chosen, before I turned my pump on, if I had chosen to do this part first, okay, scrub my hub, flush my line, make sure that it's patent. Indeed, it is patent. That's going to go away. Get my tubing. And I don't have to hang on to it because I got that alcohol under there. And connect. Okay, after priming the tubing, I could have flushed and connected. Then I could have set up my pump and I wouldn't have to listen to that beeping sound. There's different ways that you can do this. It doesn't have to be one way. And then I'm going to hit the start button here in the corner. Okay. Now, if you see this yellow marker, the pump is checking for an occlusion because it's sensing it can't flow. So if that yellow marker is on, you probably didn't unclamp it, which is true. See? I didn't unclamp it. So when you see the yellow, you might as well unclamp your tubing because otherwise it's going to holler at you and it's going to holler occlusion. If you catch it right away, it won't holler occlusion. If it hollers occlusion, who cares? Okay? You just unocclude it and restart it. Checking, I just want you to see what happens if you don't get to it. I can't tell you now. Okay, now it's alarming red and it's saying occlusion. So what do? Open up your clamp and then hit restart. Okay, and now it will infuse. All right. Now, because this is, I don't want Michelle's bed to get all wet, I'm going to drop this into the trash can. Okay, but for your purposes, this is infusing into the patient. I would add in this situation, I would take a piece of tape because I don't want that IV tubing to pull on that site. So what I would take a piece of tape to secure the tubing in such a way that it doesn't pull on the patient. And again, I wouldn't be infusing this fluid into the trash can. Okay, but just something to keep the tubing more stable. Maybe a piece up here too. Again, there's not one way to do this. It's whatever seems to work. There we go, just to keep it stable. All right, so now he's got his fluids running. Fluids are running at 125 an hour. And when this number here, which is now at 497, when it gets to 0, it's going to alarm and it's going to say the infusion is complete. You'll notice it's alarming. It says infusion is complete. You'll walk in the room. You'll go, oh, my bag is almost empty. You might have just a little bit of fluid left in the bag. If so, then just hit, it's reading complete. You'll have the opportunity to select the channel and you can change the volume to be infused. Maybe you just put 20 mils in there while you go get another bag of fluid to hang a new bag of fluid so it doesn't keep beeping until you get back. And hit start. All right, so we've taken care of the fluids. Now the next thing I'm going to do is I'm going to consider hanging the IV antibiotic and I'm going to consider giving the IV push. Well, which one do you do first? I know you can't really answer me, so I'll just tell you what you do first. You do the IV push first because if you hang the antibiotic, then you have to assure that the IV push is going to be compatible with the antibiotic that's now infusing. If you give the IV push first, you don't have the antibiotic running. Okay. So when I give an IV push medication through an existing IV, I don't have to flush before and after because the IV is patent, it is infusing. I do assess my site to make sure that it isn't swelling. And I check to make sure that the fluids that are infusing are compatible with the medication I'm giving. Normal saline is a pretty general fluid. It's compatible with almost everything. There are a few exceptions, and you would know what those are in the clinical setting. So then I find the port that's closest to the patient, and in this case it's in the trash can, so forgive me for that, but this port is infusing into the trash can, so I'm going to find that port, I'm going to scrub it. I'm going to keep the port clean. I'm going to attach my syringe, and now I'm going to give this medication at the prescribed rate. I didn't tell you what it was, so how do you decide how fast to put how fast to push an IV medication? You look it up. It depends on the medicine. Lasix, for example, furosemide, is a diuretic, and you can safely give that at 20 milligrams a minute. When you look it up in a drug book, it will say administer 20 to 40 milligrams over 1 to 2 minutes. Sometimes we give 80 milligrams of Lasix. So 80 milligrams would be over 2 to 4 minutes. So 20 milligrams a minute for Lasix is safe. The pantoprazole, the instructions are to give over 2 minutes. It just depends. So you're going to give that, and then, when it's all in, over the prescribed time, you're done. Now, the medicine that sits still in the tubing, the IV infusion is pushing the rest of that to the patient. So you don't have to flush it afterwards. You just let the pump do that. Now I'm going to hang my IV antibiotic. Hanging an IV antibiotic using a pump. You've got your sterile tubing. You have a hanger. There must be a reason for that hanger, huh? Hang the hanger. Get your antibiotic. Again, anytime you take tubing out, it'll be in full prime mode. Clamp is open. So clamp your fluids so that you're in control. I should really show you what happens if you don't clamp your tubing, okay? Can you not do this if I show you this? Because this will make a believer out of you. Sterile to sterile. Even though I forget to clamp, I'm not so bad that I don't have good technique. Okay, I may be a little forgetful, but I still have good technique. So I'm going to take that off. I'm going to take that off, keeping my thing sterile. I put this on here. And, well, gotta poke it through. And there we go. Oh dear, look. See that air in there? Now I've clamped off. As soon as I realized I did that, I clamped it off. But see all that air that's in there? And that's what you're trying to avoid. So I've clamped it off. Do it as quickly as you can. And just pinch it with your fingers when you realize you've done that. And then do that, okay? And then open it. And when you get close to the end, slow it down so that you're in control. See those air bubbles in there? That's because I didn't do it right. And this is medication, so you don't really want to lose it, but you got to get the air out of the line. Okay? All right, now my air is out of the line. Okay. A principle of gravity, and this is how we deal with the secondary infusion setups. The highest available fluids will infuse. That's the principle of gravity. So to make that happen, I have to create a distance between these two fluids. And I do that using this. Since I want to hang the IV piggyback, I need to lower. It doesn't matter if you have them on the same hook or not, but I need to lower the primary. Okay. Now, another concept that you have to think about is where am I going to plug this in? In the clinical setting and the tubings that I have at Christian Hospital, there's actually a port right below the pump. So you could plug this in below the pump. But if you plug it in below the pump, tell me what is controlling the rate. Because it won't be the pump. The only thing that'll be controlling the rate is this clamp. The whole point of running a secondary infusion through a pump is to have the pump regulate the flow. So you have to plug it in above the pump. So again, I'm going to get an alcohol. I'm going to clean that port. It doesn't matter where the port is. It has to be handled aseptically. And if you're dealing with a central line or a pick, it doesn't matter where the port is, you're obligated to that 30-second scrub. Uncap. Put that on there. All right. Now, the other thing that I've calculated as part of my clinical prep, actually, that's what I would suggest for all of you, that you not come to clinical and figure out how fast to run things then. Do as much of that as you can the night before. You'll have those instructions. So for example, this is a 50 ml piggyback and I'm supposed to run it over 30 milliliters. There's a formula and I know Michelle's going to teach you that. I see a lot of this math and I can imagine without difficulty that if I want 50 milliliters to run in a half an hour, the hourly rate would be twice that, because a half an hour is 1 out of 2 parts of an hour, so 50 and 50. So the hourly rate for this is 100 milliliters an hour. If I run this at 100 milliliters an hour, 50 milliliters will run in 30 minutes. So I have to change the rate on this pump because 125 is too fast. I want it to run at 100. So I'm going to go to channel select and I'm going to say secondary because I want to run a secondary rate. Secondary. Now you can actually look up some of these drugs. I don't let my students look them up. I want them to come to me having done the math. Because you might be in a situation where it's a brand new medicine, it's not in the pump, and you don't know how to do the math. So I'm just going to do a basic secondary, and I'm going to put the rate in. I calculated it to be 100. And I want this IV piggyback to run at 100 mils an hour until 50 milliliters infuses, because that's what's in here. 50. And now I hit start. Okay. Now what's happened, it says secondary over here. The rate is 100, and when you look at it, you know, if you don't know that this is a secondary, you might go, oh no, that IV is not running at the right rate. It's supposed to be running at 125. But it says secondary. All right, so the question is, what's running? And the answer that most students will give me is, well, it's the piggyback that's running. And I'm going to say, no, it isn't. Because this pump runs the highest available fluids. Well, I did well. My piggyback is high, but I haven't made it available yet. Look what's running. This is running. And this is running because I haven't opened the clamp. Okay. Now, you would like to think that the pump would tell you that. It does. It actually did have a notation down here that says open the secondary pump, but sometimes we don't see that. We don't look at it. It doesn't alarm. The pump will alarm if I don't let it run, but if it's able to run something, it will. So if you want the piggyback to run, you got to open the clamp. And how do you know that the piggyback is running? You know it's running because you can see it. Now you might say, well, I know it's running because I opened the clamp. I've run across a couple of situations where, although the nurse did everything correctly, there was a defect in this little attachment here, and even though this was open, there was something about the medicine that the patient had received before that kind of gummed this up a bit, and so it didn't open that port even though it was screwed on. So the way you know it's running is by looking at it and saying that it's running. So now what's going to happen is it's going to run at this rate until this ticks down from 47 to 0. When it ticks down from 47 to 0, it's going to kick back to 125 an hour. And when it kicks back to 125 an hour, let's say that this bag was really overfilled by the pharmacy. Well, the last little amount of medicine that's in the bag will run at 125 an hour because the machine's going to kick over. It doesn't have an eye looking up. It just does what you program it to do. So it runs at 100 an hour till 50 goes in, then it kicks back to 125 and it runs the highest available fluids at 125. If this is empty, then of course it's not available. And as soon as the drip chamber may empty out and you may actually get some air in this line, then it will start pulling fluid from this one. It's all gravity dependent. Okay. So I want you to imagine for a minute that all of that has happened, and the infusion, the piggyback is complete, and it's now running at 125 an hour at the primary rate. And I don't know if I can do this for you. Well, I'm not gonna do that right now. Maybe I'll do that in a little bit. All right, so this is the setup if you were using a pump to hang a piggyback, okay? So I'm gonna turn this off because I want to transition to, how you would deal with this if you had only IV fluids and no pump, okay? So I need just a quick minute here to change this setup just for your, and none of this is really happening. I was hoping to find, yeah. All right, so scenario, this patient has fluids running. They are running by gravity drip because, you know, this is a little rural hospital and they don't have pumps. We really hardly ever run anything without a pump, but it's dripping. Someone has calculated the rate and decided how fast it's going to drip. And you need to hang an antibiotic, and you want to use the primary secondary concept to do this. So you still need this thing to lower. So I'm going to lower the primary. I'm going to hang my antibiotic. I'm going to plug my antibiotic in to this port area. Scrub my port. Attach my antibiotic. And what you need to understand is I can open this, and I have to open this one wide, but what I use to actually control the rate is this clamp down here, okay? And this clamp down there, notice that this is the one that's running, not this one. Now if I clamp this off, then this runs. But it's all gravity dependent, and it's running the highest available fluids, but I control the rate using this down here. If I try to control the rate using this one here, notice what happens. Okay, they're both running. If that's what you wanted, for some reason, I suppose you could do it. But basically when we're setting up a secondary, we leave this one wide and we control with this because we want this to run in, undiluted, and then we want that to run in. You would use your second-hand watch to actually count the drops per minute that you calculated. And I'm going to let Michelle teach you how to do those calculations. All right. Now the way the order reads, when this antibiotic has infused, the patient can be disconnected from their IV. He doesn't need to have the IV on all the time. So you come back in 30 minutes and the antibiotic indeed is empty and this has started dripping, but you know that you can disconnect this patient. So to do that, you need to bring a sterile saline along and your alcohol, and you can leave this set up like this, and you're going to come down here to where the patient is connected. So pretend, you know, this is how you found it. Okay, so the IV is infusing into the patient. You come and you turn it off, okay, and you want to disconnect that. Now, policies change from hospital to hospital. Primary lines that are running continuously at Christian Hospital are good for 4 days. Anything that's intermittent is good for 24 hours. So this patient gets an antibiotic every 6 hours. So I want to save this setup so we can use it again. I am going to be very conscious about this tubing because I want to keep it sterile. This is a sterile normal saline. A couple of options you have. At Christian, we have all kinds of little caps like this. These are sterile caps. But honestly, the cap on the saline syringe is sterile too. So if I disconnect this, and I disconnect this, and I put this on here, it was all a sterile switch, that hasn't touched anything, I can just go ahead and flush it. Now, if in the process of doing this, this gets down here and touches the skin, I have an alcohol. Better safe than sorry. I have an alcohol, I can clean that, then I can use my sterile flush, disconnect, and hang my tubing up. Okay? Now, back to, I did want to show you one thing. I want you to imagine that this is connected to your patient, and I want you to imagine that you're coming in, okay, I want you to imagine that you're coming in to hang a different antibiotic, and you'd like to use this setup again, but the medicine that's in this tubing here, you don't know if it's compatible with the solution that you want to use. There's something called back flushing, and this works, you know, imagine the pump is hooked up down here. Michelle tells me I only have 2 minutes. So the pump is hooked up down here. If you take this and you turn it upside down, see, this is running wide. I don't know if you can see that, but it's running wide, and in running wide, it is flushing out the old medicine, okay? When the medicine has flushed, clamp it, take the old off, throw it away, and hang your new antibiotic. Because now what you have in here is normal saline, because you used it, you back flushed with it. And that does work. Yeah, I think that's it. The other thing that I didn't do that you need to do is make sure you get labels on your tubings, okay? There's no, you know, it doesn't have to be done in any certain time, but, you know, before you are all done, get labels on your tubing so everybody else knows what you did. All right, hopefully this is helpful. Thanks.